IV. A 56-year-old man was admitted to the hospital in autumn because of cough, hypoxemia, and a rash. The patient had been well until 9 days earlier when lightheadedness, diffuse myalgia, chills, sweats, and the extreme fatigue developed, when he thought were related to influenza. The next day, a rash, which he described a red and pimply like a beginning of a poison ivy, uh, developed over his chest and the axillae. It gradually improved but did not resolve. A dry cough developed, which prevented him from finishing the sentences. There was no pruritus, rhinorrhea, or sore throat. 5 days before admission, the cough worsened and was associated with a sharp substernal chest pain on inspiration, dry mouth, anorexia, malaise, and lightheadedness that improved with lying down. The next day, he saw his physician. The physician examination was normal. Azithromycin was prescribed. But the curve persisted, worsened, and remained non-productive. It was improved at rest, but and was worse with exertion. And while the patient was lying on his right side, fatigue increased and night sweats continued. Dyspnea while climbing one flight of chairs developed, and he was unable to take a deep breath without discomfort or coughing. On the day of admission, the patient returned to the doctor's office. The temperature was 36.7 degrees Celsius, the blood pressure normal 124/70, which while he was standing, and pulse was 76 beats per minute, the respiratory rate 12 beats per minute. The oxygen saturation was 88 to 90% while he was breathing ambient air. He was sent to the emergency department at his hospital. He reported no weight loss, wheezing, or nausea, vomiting, abdominal pain, or urinary symptoms. He had history of hyperlipidemia, hypertension, gastroesophageal reflux disease, and depression. He was born in Spain and immigrated to the United States as an infant. He had lived in Florida, the Caribbean, and most recently the Northeast. 3 weeks earlier, he had returned from a 2-week trip to Arizona, where he had stayed in hotels, eaten well cooked meals, and gone horseback riding in the desert and mountains approximately 4 hours per day, including participating in the cattle roundup over the windswept plain. He had also traveled to the Wyoming for a houseback riding trip 5 months earlier, and he had been to Spain and England in the past. He was married, monogamous with his wife. He self-employed in construction. He owned cats, was not aware of any ticks or flea bites, and had not been swimming. He drank alcohol moderately and did not smoke or use illicit drugs. His mother had died of esophageal cancer, and his father had a history of alcohol abuse. Medications includes he's on medications like on simvastatin, extended release venlafaxine for depression, and buspirone hydrochloride. He had no known allergies. On examination, I could start.
हाँ हाँ
So main
हाँ रुको हाँ so this is a hello
yes, sir.
so this is a 55-year-old man who has come with cough, dyspnea, hypoxia and rash.
Yes.
फीवर का हिस्ट्री नहीं है.
फीवर का हिस्ट्री नहीं है.
Okay. And he has had a recent trip to Arizona.
Yes, sir. Arizona.
So what is your diagnosis?
Like some viral infection or fungal infection.
So probably a viral infection because he has a rash associated and cough. Some respiratory viral infection, sir.
See, 9 दिन का history है ना, 9 days of symptoms.
Yes,
Yeah,
sir.
9 days.
बराबर?
Right.
So viral is possible, but viral में fever आएगा. And viral will not have any of this history of going to Arizona. So Arizona में basically, if you know a little bit about US, so Arizona is a desert area.
Desert area.
So you get some strange fungus there which you don't get anywhere else. The dimorphic fungi. So this is likely to be one of the dimorphic fungus because it is fitting into the cough, dyspnea, rash, but no fever. तो ये शायद ये कॉक्सीडियोमाइकोसिस, पैराकॉक्सीडियोमाइकोसिस, हिस्टोप्लाज्मोसिस इसमें से कुछ है।
Yes, sir.
बराबर। हाँ। तो ठीक है, आगे सुनते हैं। अमित इतना हंसने लगा है कि आई थिंक ही नोज द आंसर।
सर रीड किया मैंने भी जस्ट थोड़ा पहले।
ओके ओके, पढ़ो पढ़ो।
On examination, the temperature was normal. The blood pressure was 130/70. The pulse is 72 beats per minute. The respiratory rate was normal. The oxygen saturation was 90. He was breathing ambient air, and 96% while was breathing 4 liters of oxygen via nasal cannula. The oral mucosa was dry. There were crackles in the middle and lower fields of the left lung and in the right lung base, with egophony on the left. Egophony on the left. A faint morbilliform rash was present on the flanks bilaterally. There was no edema or clubbing. The remainder of the examination was normal. Urinalysis revealed ketones positive 1 plus and was otherwise normal. Levels of the electrolytes, calcium, magnesium, phosphorus, and other tests of the renal function were normal. Okay. The ECG will revealed left atrial enlargement and intraventricular conduction defect. Chest radiograph revealed bilateral patchy opacities, more in the right lung than in the left lung. CT of the chest performed according to the protocol of the pulmonary embolism, and which revealed multifocal consolidation and the ground glass opacities in all lobes of the both lungs, most marked in the right upper lobe, and the bilateral halal lymphadenopathy that measured up to 2.3 centimeter. There was no evidence of any pulmonary embolism. The administration of the levofloxacin was begun, and the patient was admitted to the hospital.
Okay.
So on the second day, the testing of the nasal swab specimen was negative for the antigens of the adenovirus, influenza A and B, respiratory essential virus, parainfluenza virus.
Basically, the hilar adenopathy again goes in favor of dimorphic fungus. Okay. Hilar adenopathy you generally see in TB, sarcoid, and the dimorphic fungus. And consolidation also we are seeing more in the upper lobe. That also is common in this. So O.P. Kapoor used to teach in this way that whatever TB can cause, histoplasmosis can also cause. The presentation can be very similar. Okay? बोल आगे बोल.
So on the second day, the testing of a nasal swab, ये तो बोला था हमने. नहीं ये. अच्छा. Gram staining of the sputum specimen showed squamous epithelial cells, a few polymorphonuclear leukocytes, and very few mixed gram-positive organisms, and a fungal wet preparation showed no organism. Culture of the specimens of sputum, blood, and urine were obtained. Additional test, I will tell you, sir. Additional test have a paragraph. On the fifth day, a specimen of a peripheral blood and analyzed by means of a flow cytometry revealed 92.7% T lymphocytes, but was otherwise normal. Cultures of the blood and urine were sterile. A urine test for Legionella antigen and a serum test for antibodies to Legionella pneumophilae serogroups were negative, and antibody testing was equivocal for non-pneumophilia species. So, differential diagnosis है.
हाँ, कोई ऐसा कुछ लिखा नहीं? On this day, a diagnostic test was performed. Usually ऐसा sentence डालते हैं ना?
हाँ, ये पहले स्टार्टिंग में बताया लोग ने कि पहले लाइक पास्ट का बता रहे थे. एडमिशन हुआ था, उसके पास 9 डेज का क्या क्या हुआ इसे बताया लोग ने.
हाँ, ठीक है.
डिफरेंशियल डायग्नोसिस में पल्मोनरी इन्फिल्ट्रेट सबसे पहले वो है डिफरेंशियल.
हाँ, क्या क्या मेंशन किया है उन्होंने?
Atypical pneumonia due to mycoplasma or chlamydophila often presents with an influenza-like illness and dry cough
ये
and chest
नाम
pain.
नाम 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 बोलते जा. डिफरेंशियल क्या क्या बोला है? जस्ट फॉर यू टू लर्न द डिफरेंशियल.
Legionellosis.
डिटेल्स बाद में पढ़ो तुम. हाँ
हाँ, Legionellosis.
हाँ और
Eosinophilic lung disease.
ओके और
Pulmonary infections associated with eosinophilia. उसमें सब
ओके
वो सब आएंगे. TB, helminthic infections, tropical pulmonary eosinophilia.
हाँ
और मेनली साउथ वेस्टर्न यूनाइटेड स्टेट्स में ये फीवर्स है. क्यू फीवर कॉज्ड बाय कॉक्सिल ऑफ बर्निटी और हंटा वायरस पल्मोनरी सिंड्रोम एंड कॉक्सिडियोइडोमाइकोसिस.
हाँ. तो फाइनली
Summary में यही है. In this man who had cough, rash, eosinophilia and diffuse pulmonary infiltrates on imaging and who had recently traveled to an area where coccidioides species were endemic, the most likely diagnosis is coccidioidomycosis. The most direct diagnostic procedure would be identification of the pathognomic sperules on the bronchoalveolar lavage. Pathognomic sperules.
ओके.
Clinical diagnosis coccidioidomycosis.
फाइनली क्या किया उन्होंने? बाल किया.
Yes, sir.
हाँ, pathological discussion. Although direct detection, culture, and antigen testing can be valuable tools in the diagnosis of coccidioidomycosis, they afford relative poor sensitivity, particularly when the infection is not severe or disseminated. Therefore, antibody tests are frequently relied on to support or establish the diagnosis. In this case, the serological findings support the clinical diagnosis or pulmonary coccidioidomycosis. So finally, you लोग ने the initial treatment.
हाँ बोलो ना. ट्रीटमेंट बोलो. क्या किया उन्होंने?
The initial plan was to complete a 6-month course of therapy. A steady resolution of the symptoms occurred, but in view of the severity of the patient's pneumonia and the fairly slow radiographic improvement, his caregivers decided to extend his course of fluconazole therapy for a full 12 months. बाल क्यों नहीं? उन्होंने क्लिनिकली डायग्नोस किया कुछ. हाँ,
तो
बायोप्सी.
एंटीबॉडी वगैरह नहीं? एंटीबॉडी नहीं किया?
एंटीबॉडी तो पहले किया वो लोग ने. क्या बता ना.
पॉजिटिव है एंटीबॉडी.
हाँ,
Not detected.
not detected either. Coccidioidal antibody was not detected by the quantitative complement fixation test.
So they did it after 15 days. They did the quantitative fixation, immunofixation test. So this may antibodies were not detected, sir.
1 day after the initial.
ठीक
और
है. तो बाद में क्या हुआ?
ग्राम स्टेन में भी रिवील नहीं किया वो जैक्सन. Fungal wet mounts and routine fungal cultures of the sputum and urine did not reveal any organisms.
So they gave basically fluconazole.
Empirically started.
Patient improved.
Patient improved.
Then patient improved.
Yes.
I think initially
beta-glucan and galactomannan be negative था.
So the second procedure they did was a punch biopsy of one of the skin lesions on the left flank. So in that punch biopsy, they have shown that there was a perivascular lymphocytic infiltrate and focal vascular interface dermatitis. And on high resolution, it showed intercellular bridges accentuated by intradermal edema. And there were eosinophils seen in the dermis, sir, which was evident of a hypersensitivity reaction.
Okay. So the patient improved on flucon.
Yes, sir.
Yes. Glucon symptom.
I think
So what they are saying,
some
this cutaneous manifestation of coccidiomycosis was a ID reaction, the allergic reaction to the
yeah,
fungus.
yeah.
ID.
So as far as I remember, I think डायमॉर्फिक फंगस में पहला ट्रीटमेंट एम्फो होता है, बाद में इट्रा होता है. बट
Yes,
कॉक्सीडियो भी इंडिया में दिखता नहीं है, तो मैंने पढ़ा नहीं है ज्यादा.
Okay.
तुम लोग पढ़ो हैरिसन में से, बताओ क्या है. हाँ?
so initially this patient was started with levofloxacin for presumed community acquired pneumonia. And then once
Yeah.
coccidiomycosis was suspected, they started with fluconazole 100 milligrams a day, which showed a very rapid improvement in his hypoxemia, shortness of breath, and cough. And on hospital day 5, the patient was discharged on oral fluconazole, sir. And he
Okay.
was given 400 milligrams daily for 12 months, sir.
Okay.
And within 1 month after discharge, his eosinophil count was also normal, and patient felt well, and he also returned to work. His
Correct.
pulmonary
So I think
were also resolving slowly.
yeah. So I don't think there is any doubt in the diagnosis. Only thing is just check on the treatment part. What is Harrison saying of coccidio? For some reason, I remember by hearting amphotericin plus itraconazole for all dimorphic fungus. Coccidio, paracoccidio के लिए कुछ अलग है क्या, देख लो एक बार.
Yes, sir.
हाँ. और एक केस प्रेजेंट करो. ये सारा डिफरेंशियल आप डिटेल में पढ़ो, हाँ, बाद में.
Yes, sir. They have given a nice
Because
table, sir, about multifocal pulmonary infiltrates. So जिसमें infectious, neoplastic and inflammatory और allergic origin, वैसे 3 उन्होंने differentiate
सब
किए. So in
yes,
infectious,
बराबर.
we have said bacterial pneumonia, Pneumocystis jirovecii pneumonia, fungi like endemic mycosis and aspergillosis, TB, parasites like Ascariasis, strongyloids, and Paragnomicus and Trichinella, which can all cause eosinophilic pneumonia, and tropical pulmonary eosinophilia caused by filariasis. And neoplastic, they have mentioned lymphoma and bronchoalveolar cell carcinoma. Sir.
Correct. So tropical pulmonary eosinophilia भी आप डिटेल में पढ़ो. That's a long
Yes,
question that used to come during our time. उसका एक बहुत specific definition है. You should know the small subtle differences between tropical pulmonary eosinophilia versus paragonimus versus some other pulmonary eosinophilic infiltrates.
Yes,
So हर बार कुछ लंग में मिला और eosinophilia मिल गया मतलब tropical eosinophilia ऐसा नहीं होता है. There can be other reasons. Neoplasia is one of them. ये सब पढ़ लो बराबर से.
Yes, sir.
अभी एक और केस प्रेजेंट करो.
इन्फेक्शियस के नहीं है शायद, दूसरे
ये
करो कुछ भी, न्यूरो छोड़ के कुछ भी करो.
Yes, sir.
न्यूरो और कैंसर छोड़ के कुछ भी करो.
So this is a case of a 77-year-old man who was transferred to this hospital because of leg edema, hematuria, and acute renal failure. So the patient had a history of hypertension, atrial fibrillation, and an aortic aneurysm. He had been in his usual
एक
health.
सेकंड ना.
Yes, sir.
वेट. हाँ. So leg edema, hematuria,
and acute renal
and
failure.
acute renal failure.
okay. So this was an elderly person, 70-80-year-old, ना?
Yes, sir. 77-year-old male. He has a
हाँ.
history
तो
of
क्या,
hypertension.
रुक जा.
Yes, sir.
So at this point, at the end of chief complaints, what are you thinking?
Possibly some glomerulonephritis, sir, because the patient has a acute renal failure with hematuria, and pedal edema. So probably
Correct.
something which is causing the damage to the glomerulus.
Yeah, so this is called as nephritic syndrome. Na?
Yes, sir.
Nephrotic syndrome, everybody knows. Heavy proteinuria with leg edema, but normal creatinine, no hematuria. No. Nephritic syndrome is hypertension, hematuria, acute renal failure. बराबर?
Yes, sir.
So nephritic syndrome के क्या causes होते हैं?
Nephritic syndrome can be caused by post-streptococcal glomerulonephritis or
IG nephropathy और membranous तो है वो तो पैथोलॉजी है
हाँ
Membranous नहीं करेगा. IgA and PSGN करेगा. Membranous नहीं करता.
membranoproliferative है and
Yes,
RPGN rapidly progressive glomerulonephritis sir.
correct. Yeah, RPGN can have many causes, including
Yes, sir.
vasculitis,
Quasi-immune and
lupus nephritis
lupus.
lupus nephritis sir.
So nephritic syndrome का approach you should know. It's very important.
Yes, sir.
ठीक है. हाँ. बोलो आगे बोलो. हाँ?
So the patient had a history of hypertension, atrial fibrillation, and an aortic aneurysm. He had been in his usual health until approximately 1 month back before the admission, after which bilateral lower leg edema developed, followed by a red rash on his feet. He saw his physician, who noted worsening hypertension. The patient's antihypertensive medications were changed, including discontinuation of amlodipine, a short trial of atenolol, which caused increased shortness of breath and wheezing, and initiation of diltiazem was done without improvement in blood pressure control and peripheral edema. 20 days before the admission, he saw his cardiologist and reported leg swelling and dyspnea. On examination, the blood pressure was 156 by 90 millimeters of mercury and pulse was 70 beats per minute, irregular rhythm, plus 3 plus lower limb edema. Diltiazem was stopped and chlorthalidone was started for this patient. At a follow-up visit 5 days later, the patient reported slight improvement in his dyspnea. His weight had decreased 3.6 kilograms and blood pressure now was 146 by 80 millimeters of mercury. His blood urea nitrogen level was 34 and creatinine was reported to be 1.4 in the previous year. The previous year was 22.7 milligrams and chlorthalidone and lisinopril were stopped for this patient and a follow-up was scheduled. Medications also included aspirin 81 milligrams, terazosin, and a combination of oxycodone and acetaminophen. During the next week, subjective fevers and shaking chills developed. Chest tightness occurred occasionally, but dyspnea on exertion lessened. 6 days before this admission, 2 episodes of vomiting with non-bilious emesis and 1 episode of hemoptysis occurred. The urine appeared dark red. The next day, the patient went to the emergency department at another hospital. On examination, his height was 170 centimeters, weight was 72 kgs, blood pressure was 141 by 85, and the pulse was 80 beats per minute and irregular. Temperature was 36.7 degrees Celsius, which was normal. Respiratory rate was 22 breaths per minute, and O2 saturation was 98%. While the patient was breathing ambient air, there were fine crackles on the base of the left lung and a papular rash on the leg without peritibial edema. The other examinations were normal. Blood level of total protein, phosphorus, magnesium, total bilirubin, amylase, creatinine kinase, lipase, uric acid, IgA, complement C3, C4, and IgG were all normal, as were the tests of coagulation and liver function, which were normal. Testing was negative for antibodies to glomerular basement membrane and to ANCA,
एक
including.
second. I
Yes, sir.
just wait 1 minute.
Yes, sir. But IgA not. IgA not.
हाँ हाँ बोलो.
Yes, sir. So, just summarizing the test, sir. So, the IgA, IgG, and complement C3, C4 were normal. His LFT and coagulation profile was also normal. Testing for antibodies to glomerular basement membrane was also negative. And for ANCA, including C ANCA and P ANCA, both were negative.
Okay.
Such specimens of blood and urine were cultured, and IV fluid was administered, and ceftriaxone was started for this patient. Patient was admitted to other hospital. Renal sonography reported abdominal aortic aneurysm of 8 centimeters. CT of abdomen and pelvis without administration of contrast revealed a circumferential fusiform aneurysm of 8.3 centimeters in the infrarenal abdominal aorta and other aneurysm of 2 centimeters in the right iliac artery. So terazosin, lactobacillus, heparin, clonidine, omeprazole, ferrous sulfate, nifedipine, and pneumococcal polyvalent vaccine were given to the patient. The blood level of creatinine was on rise daily. On the third day, testing for anti-nuclear antibodies was negative. No monoclonal immunoglobulin was detected. On second, third, and fourth hospitalization day, the patient was started on methylprednisolone, 500 mg daily. And on third day, insulin was added to the patient. A unit of leukocyte poor packed red cells were transfused. On the fifth day, blood cultures were drawn on admission. Which were drawn on admission came back negative. A renal biopsy was performed on the patient, and the next afternoon, the pathological examination of biopsy revealed mild proliferative glomerulonephritis with crescents, segmental nodular glomerulosclerosis, diffuse linear immunoglobulin immunofluorescence reactivity for IgG along the glomerular basement membrane, and signs of active and healed mesangiolisis, moderate tubular atrophy, and widespread endothelial cell injury. And the patient was then transferred to this hospital. The patient. So now the patient also has pulmonary involvement in form of hemoptysis, and on biopsy, it is showing IgG reactivity to glomerular basement membrane. So it looks like pulmonary renal syndrome or good pasture syndrome, sir.
Correct. So see, basically nephritic syndrome को कैसे approach करना है ना? Is you have to do antibody tests, autoimmune workup. उसमें कुछ नहीं मिला तो you have to go for renal biopsy. Without that you can't get the answer. Renal biopsy में जो pattern दिखा उसके बाद तुम पीछे जाके ये कर सकते हैं, सोच सकते हैं कि क्या cause रहेगा. काफी बार cause नहीं मिलता है, then we call it as idiopathic. So in this case, we were thinking of nephritic from the chief complaints only, and we thought of membranoproliferative, and we found it on the biopsy, membranoproliferative. And उसमें कैसा है कि देखो उसमें ना in the renal biopsy when you do immunofluorescence staining, so you can see 2-3 different patterns.
Yes, sir.
One is a linear, diffuse linear involvement, which we see in the good pastures. Basically, that is just a single antibody lining some of the basement membranes. If there is an immune complex deposition, which we see in some types of lupus nephritis, then you will see bumps. You may see a dotted pattern with bumps. ठीक है? तो ऐसा अलग-अलग type है. I've forgotten now some of the other types, but वो photographs are very characteristic. Like you see in the books, ना इसमें रॉबिन्स या हैरिसन में आप देखेंगे ना इसके फोटोज ग्रीन वाले.
Yes, sir.
इट्स वेरी सिंपल, मींस एनीबॉडी कैन से कि ये लीनियर है, ये ग्रैनुलर है. ग्रैनुलर एंड लीनियर, दीज आर द टू पैटर्न्स, एंड देन देयर मे बी कॉम्बिनेशन.
Yes, sir.
तो उसके हिसाब से समझ जाता है. हाँ. So now linear आया है तो good pastures is most likely even though this earlier the antibody test came negative. बराबर.
Yes, sir.
हाँ. So basement membranes of the renal uh, nephrons and it has antibodies against the lung. So basically it's an autoimmune kind of disease.
Yes, sir.
Renal involvement will come in the form of nephritic syndrome, membranoproliferative glomerulonephritis, and the lung involvement will come basically infiltrates only. Treatment will be steroids and then cyclophosphamide, rituximab, that kind of thing. So mainly, see, it's a purely type 2 type of hypersensitivity, right? So types of hypersensitivity क्या होते हैं? Type 1 is
IgE associated, sir. Type 1.
immediate IgE associated is
IgE
type 1
associated.
hypersensitivity. Type 2 is antibody against something.
Antibody antigen.
Huh?
Yes.
Type 3 is
Immune
immune
complex.
complex deposition.
Yes, sir.
And then type 4 is a delayed T cell mediated.
Yes, sir.
बराबर. तो इनका हर एक का, so if you see the pathophysiology of many autoimmune diseases, तीनों का ट्रीटमेंट थोड़ा अलग अलग होता है. टाइप 1 में मेनली इट इज जस्ट स्टेरॉइड एंड रिवर्सेस. टाइप 2 में इट्स मेनली एंटीबॉडी मीडिएटेड. बराबर. तो प्लाज्मा फेरेसिस rituximab. These are some of the main treatments for all type 2 hypersensitivity वाले mechanism वाले जो diseases होते हैं ना उनके.
Yes,
So autoimmune hemolysis, autoimmune problems in SLE, rituximab and plasmapheresis. So myasthenia gravis is a purely type 2. उसमें कोई डिपोजिशन नहीं है, प्योरली टाइप 2 एंटीबॉडी मीडिएटेड है, तो उसमें भी प्लाज्माफेरेसिस आता है.
Yes, sir.
बराबर. IVIG, plasmapheresis are two main lines of treatment in a purely type 2
Yes,
thing. Huh? Immune complex deposition रहेगा तो you can't really do much with plasma because the antibody is already bound to the antigen and the combination has deposited in the tissues causing problem. So now the things which remove antibody from the system are not going to help. बराबर. मीन्स तुम प्लाज्मा फेरेसिस करके एंटीबॉडी निकाल दोगे या आईवीआईजी से एंटीबॉडी को ब्लॉक कर दोगे तो भी कुछ फायदा नहीं होगा. तो फिर इम्यून कॉम्प्लेक्स डिपोजिशन वालों का ट्रीटमेंट थोड़ा अलग होता है. इम्यून सप्रेसेंट रहेंगे बट these things will not work as well. IVIG, plasmapheresis and rituximab will not work so well. Sometimes they may work but not so well. So then you have to go for cyclophosphamide and all that. Type 4 में again mainly it's a TNF alpha mediated granulomatous things can also come. तो उसमें ये सब आता है फिर अपना थैलिडोमाइड, साइक्लोफॉस्फेमाइड, माइक्रोफिनोलेट, साइक्लोस्पोरिन, जो टी मीडिएटेड वाले हैं ना सारे, जो मेनली अपन ऑर्गन ट्रांसप्लांट रिसिपिएंट को देते हैं, वो सब आते हैं फिर उसमें. So this way you have to organize, you can organize the whole of rheumatology and a lot of neuro and nephrology just based on the type of hypersensitivity which is the pathophysiology of the disease. Barabar. Now GBS is again antibody mediated. Ganglioside antibody ना. तो क्या है treatment? IVIG. बराबर. ठीक है. Now so many of the things so infliximab etanercept comes in type 4 mainly. तो उसमें तुम्हारे वो आते हैं टाइप 4 वाले कौन से, रूमेटॉइड आर्थराइटिस एंड सीरोनेगेटिव स्पॉन्डिलोआर्थ्रोपैथीज. बराबर. तो उसमें ये इसका काम नहीं आएगा कुछ, प्लाज्माफेरेसिस आईवीआईजी का काम नहीं आएगा. पहले आई यूज्ड टू गेट वेरी कंफ्यूज कि कोई कोई ऑटो इम्यून डिजीजेस में क्यों आते हैं ये, बाकी में क्यों नहीं आते. एक बार मैंने बैठ के पूरा एनालाइज किया, तब मुझे ये ऐसा मिला. मैंने एक ऐसा मास्टर चार्ट बनाया फिर जिसमें ये ऐसे कर दिया. ठीक है. तो rheumatoid arthritis, so things which will have granulomas na, they are type 4 mediated. And unka treatment is mainly what we use for rheumatoid arthritis will be the treatment. Means
Give
हमारा
that-
methotrexate,
Yes.
methotrexate, steroids, thalidomide, lenalidomide, and your cyclosporin, MMF and cyclophosphamide. ये सब उसमें आएंगे, बराबर. So these are very erosive arthritis वाले उसमें आते हैं वगैरह.
Yes, sir. Sir, वो सेशन एंड होने वाला था अभी.
हाँ.
So I'll have to restart it, sir, in 1 minute.
Restart करते
Yes,
हैं
sir.
restart. हाँ.
Yes, sir.
हाँ. So this